Good morning, and welcome to the Controlling Exposures to Unregulated Substances webinar for Community Social Services. My name is Tigran Bajgoric, and I'll be your host today and one of the co-presenters. I'm excited to have you all with us today as we explore inhalation exposure risks to fentanyl and other drugs, a topic of interest in our harm reduction sector. As an occupational hygienist, this is a topic that I find quite interesting, and this has been an emerging risk for our employees in the sector, and I'm glad that somebody from the advisory panel suggested that we do a webinar on this topic. And just before we get started, I would like to cover a few items. This webinar is being recorded. The webinar will be posted on our website and our YouTube channel after this event. I invite all of you to visit our updated website, sign up for our newsletter if you haven't signed up already, and all participants will receive a certificate of attendance, which will be posted in our new LMS, which is coming to you really soon. We already have testing going on with a number of organizations in our sector. So as we get started, first of all, as we get started, I want to acknowledge the unceded traditional lands of more than 200 distinct First Nations in British Columbia. Myself, I'm calling in from the unceded traditional territories of the Musqueam, Tsleil-Waututh, and Squamish First Nations. In our work and in our lives, we're committed to listening and learning, to truth and reconciliation, and to finding better ways to being on this land. We want to recognize the original caretakers of these lands, and as a learning organization, one that counts many Indigenous organizations as members, we always want to find better ways of integrating Indigenous ways in our health, safety, and well-being programs. And especially in these changing political times, it is important that we as an organization are working towards that goal. So first of all, as we get started, I just want to acknowledge our panelists for today. Today with us, we have Farzad Kasad, Senior Labor Relations Officer, Health and Safety with the Health and Sciences Association. We also have Natalia Day, Occupational Health and Safety Manager, Victoria Kool-Aid Society, who will be sharing her experiences with this topic today, and myself with the Community Social Services Health and Safety Association. I also want to share that our team has been growing, so we recently hired 2 safety advisors to our team, and we're excited about the opportunity to serve and support the social services sector with these new resources. So if you know a little bit about us, we know that we have 3 classification units, and so anybody who is signed up with those at WorkSafe BC is automatically our member. So that is counseling and social services, life and job skills training, and residential social service facility. And so as members of our association, we're always interested in hearing from our members, and we'll be sharing a survey in the next month to learn more about how you want to be supported by our association. We want to gather some insights about violence prevention and other services, and determining sort of the direction that we're going to go as an organization. This information will be utilized and presented to the board in September as we have our next planning meeting in order to determine what exactly projects and initiatives will be prioritized by this organization. So your feedback is important to us as we build this organization as a support service for you. And one of the things that we've been also working on is an associate membership policy. We noticed that there's a lot of organizations that are reaching out that are in the sector, but not necessarily signed up in those classification units. So we're looking at different ways that we can support them and be part of this association. Yes, this recording will be available at a later date. Thank you, Natalia. Great question. So next, as we get started, just wanted to share with you the topics for today. So on our agenda, we'll talk a little bit about the regulation. We'll talk about symptomatic exposures in regards to fentanyl and other drugs. We're going to talk about how to investigate these types of incidents in your organization. We're going to talk about one employers, so Kool-Aid Society's sampling campaign and how they would manage to measure exposures in their organization. And then how do we control exposures what are some strategies that we can use to minimize the risk to our employees and create a healthier work environment. We'll talk a little bit about a hierarchy of controls and then finish off with so what's next from us as an organization. So welcome to everybody. As we get started, I'm really gonna talk a little bit about introduction still. So, as you know, the priorities of our organization is developing education and training. So there's a number of courses that we've already developed, and there's a few more that are coming, and this all will be launching very soon as we're now in the piloting and testing stage with our, I think nearly 40 different organizations have volunteered to kind of test our LMS. So we're excited about this and the courses that will be coming your way. All the online catalog courses will be free as a resource to the sector. So we're really excited about that. We're also, of course, working on different resources and templates and program templates, and some of them are already available on our website, and many more are coming your way. We're just reviewing them and tailoring them and customizing them right now to the sector, with the goal to support organizations to develop compliant and best practice health and safety programs. And then the other priority, of course, are webinars. So how we chose this topic is either we work with our advisory panel, we work with our community practice, and with you, our webinar participants, to determine what topics you would like to see as part of our presentation. So your input is put on a list, and then we are presenting that always to the advisory panel to vote on the best choices for the upcoming year as we then prepare these presentations. So your input is valued, and we would love to continue hearing back from you. And so thank you. So I'm going to pass it on right now to my colleague, Natalia.
Excellent. Thank you so much, Tigran. Hi, everybody. It's so great to be here with all of you today. Thank you so much for joining us. So as Tigran mentioned, my name is Natalia Day, and I'm the manager of occupational health and safety at the Victoria Kool-Aid Society. And today I'm going to be sharing a little bit about our experience with regards to exposures to unregulated substances, some of the things that we've learned, some of the challenges and some of the successes that we've had there as well in terms of reducing the exposure risks. Just to briefly mention, the Victoria Kool-Aid Society operates 21 locations here in the capital region on Vancouver Island. That includes many supportive housing sites, emergency shelters, and healthcare services for the unhoused, marginalized, or otherwise at-risk populations. We have, I think, just over 350 employees, including mental health workers, harm reduction workers, cooks, janitors, nurses, and other health professionals. So in thinking about this topic, we figured it might be a nice spot to start just by touching on the WorkSafe health and safety regulation that would be applicable to this topic. And I like to bring that forward because the health and safety regulation can help support and guide our work when we're met with a challenge in the workplace in terms of health and safety. It's always good to look to the regulation and say, hey, what is it that the regulation says we should be acknowledging here? So as it says on the slide, we know that the Act and the regulation set out legal requirements that must be met in workplaces, and the Act provides that legal authority and framework for WorkSafe BC to enforce the regulation. So these are kind of like the minimum standards, the things that we have to do, including responsibilities for employers and employees. And generally speaking, the employer is responsible to provide that healthy and safe workplace, communicate and correct hazards, provide PPE and training and all of that good stuff. So with respect to controlling exposure to unregulated substances, there are a couple applicable regulations, and I can certainly share the links for these in the chat. But one area that is good to take a look at would be Part 4, general conditions. There's a piece there around indoor air quality. And if you take a close look at that, in Part 4, it lets us know that the employer must ensure that indoor air quality is investigated when complaints are reported. So this was something that came forward in my organization, really tipping us off to the fact that there was something here that we needed to look at. workers know best. They're out there in their work environment, and they're starting to report concerns with the indoor air quality. Part 4 goes on to say that when those complaints are reported, the employer is responsible to conduct some sampling for airborne contaminants that they suspect might be present. So, we're in a supportive housing environment or a shelter environment where people are active in their substance use. Maybe they're using indoors. We also have a couple overdose prevention sites. So we know that people are smoking those substances, in those spaces. So naturally, we need to think about doing some sampling for those types of airborne contaminants. So part 4 is a good one to look at. The other one that's applicable here would be part 5, chemical agents and controlling exposures. And if you take a close look at that, what you'll find is that if a worker exhibits signs or reports symptoms of overexposure to a substance in the workplace, the employer has a responsibility to then investigate it, and we want to go through the motions there and find out why. What is the root cause of that exposure, and what can we do about it? So those were the parts of the regulation that really helped move us forward in terms of exploring this issue. So I definitely wanted to share those because I think they're a really good resource if you're trying to think about, what step to take next. And then just the last piece on this slide here, is around occupational exposure limits. So occupational exposure limits are outlined in the health and safety regulation, and unless otherwise determined by WorkSafe BC, an employer must ensure that workers are not exposed to substances exceeding those thresholds. So occupational exposure limits are established by a research body that's known as the American Conference of Government Industrial Hygienists, or the ACGIH. And they're really the group that is working to mandate and advance occupational health and safety practices around protecting workers from exposures. So I guess simply put, an occupational exposure limit is the maximum allowable concentration of a hazardous substance that a worker can be exposed to in the workplace without experiencing adverse health effects for a period of time. So we can talk about on the next slide there, thanks, that's the one, thanks Tigran, how this relates to fentanyl. So very recently, in January of 2025, the ACGIH limit for fentanyl was accepted by WorkSafe BC. And the way that we see that expressed in the regulation is through what's called a time-weighted average. So you'll see on the slide there a couple of numbers and some kind of funny looking things there. I can explain what that means. So a time-weighted average for an 8-hour shift, the occupational exposure limit has been calculated at 0.1 micrograms per meter of cubic air. So it's kind of hard to picture that, right? If you can picture what 1/1,000,000th of a gram might look like per a cubic meter of air space occupied, that's what we're talking about. And then there's a 12-hour limit as well, which you can see is half of that, 0.05 micrograms per cubic meter. So depending on the work shift, we want to make sure that appropriate calculations are done so that we understand what the occupational exposure limit is. And I just see a couple comments in the chat. What tools do you use to measure air quality? We're going to get into that. We got some fun pictures and all kinds of stuff to show you there. So just hang tight. Yeah, so these are our exposure limits. Yeah, I think that's probably all I wanna say about that, and then we'll get into some other pieces here in a moment.
Thank you, Natalia. So next, we just wanted to kind of highlight this piece around exposure control plans. So that's a WorkSafe BC requirement, and it's the language used by WorkSafe BC and health and safety professionals. So and it's basically a term that describes a distinct set of requirements that helps us create a plan for reducing exposures to different substances that pose a health risk. So for example, If we're talking in construction, it's common to develop a silica or lead exposure control plan. In healthcare and in social services, we developed exposure controls plans for hazardous drugs. But more particularly in social services, if you're working in harm reduction, you might need an exposure control plan for fentanyl if your employees are at risk of inhalation or other way of getting exposed to this substance. Another common one would be asbestos or other biological agents. So what is an exposure control plan? So basically, it's a set of requirements that you would create in order to minimize your exposure. So that would mean having a statement of purpose and responsibilities in the document that tells who is responsible and what's their policy. How do we it would behave have an element of a risk assessment, so risk identification, assessment and control, an element of education and training so that employees are educated on the different controls that you're utilizing. You would have written work procedures. Sometimes you might need to have hygiene facilities or decontamination procedures, depending on the type of situation. You might even do health monitoring. So when in certain situations. So those are sort of the requirements for the exposure control plan. And always the best practice is, of course, to involve and consult with your joint health and safety committee, or if you don't have a committee, your worker health and safety representative, and of course your staff, because your staff understand best how the work is done. And so when you're designing controls and designing sort of your mitigation strategies, you really want to be involving the staff that are in those situations. So that's a little bit about exposure control plan and the set of requirements that exist. And that's really the exposure control plan is sprayed throughout the different regulatory sections when we're talking about exposure to physical or biological agents. So yeah, you will see this term and in the future, I hope to have many different templates in order to assist organizations on developing one. If you don't have one, partnering up with an occupational hygienist or a safety advisor is best practice in order to, create a compliant plan. So moving forward, I think passing it on to my colleague Farzad.
Yeah, thanks, Tigran, and hello, everyone. So great to be here today, and thank you for joining in. We're just going to take a look around the province of British Columbia to see some media reports that have been in the news, specifically two long-term care sites in Island Health and an administrative penalty against Interior Health. And then we're going to look at some trends and patterns and some of the lessons learned from these incidents. So Summit and Dufferin Place are both long-term care sites located in Island Health, which had a special population unit for patients with complex physical, mental, and behavioral issues, sometimes including addiction. So you can imagine that bringing this type of population into a long-term care site, the staff that were already working there may not have had the best understanding of how to deal with such a complex population with complex care needs. So there was a compliance agreement with both Summit and Dufferin Place, and some of the key findings from both sites were that the employer had failed to instruct workers who may be exposed to the risk of violence in procedures for reporting, investigating, and documenting the many incidents of violence that were happening at both sites. That the employer did not ensure that workers who are or may be exposed to unregulated substances had written procedures prepared and available to workers who were trained and educated to implement them. The employer did not control the exposure of workers to environmental tobacco smoke or e-cigarette vapor at a workplace. The employer had failed to investigate and assess the potential for exposure in the case of a worker who had exhibited signs or reported symptoms of overexposure to a hazardous substance. And finally, that reports had been made to supervisors and to the employer, but there had been no adequate investigations or corrective actions that were taken. So I think in both instances, some of the both instances from both care sites, some of the trends and patterns that we were able to sort of glean from this were that in both cases, there had been a failure to communicate and in some cases create safe work procedures related to proper respiratory protection. When working around smoke and vapors, there was a lack of training for workers on exposure to uncontrolled substances, policies, and procedures. and there was a lack of proper investigation into exposure incidents and a lack of follow-up on corrective actions related to exposure incidents. This sort of carrying on from this and just looking at some of the themes from these particular incidents that took place at Summit and Dufferin, there was an administrative penalty against Interior Health stemming from an April 7th, 2024 incident where the employer had failed to provide requisite information to some facility management staff who went into a patient room and were inadvertently exposed to a substance or an unknown substance. These violations immediately resulted in a $224,000 fine to Interior Health for lack of training for workers on illicit substances safe work procedures and a failure to implement written procedures to eliminate or minimize risk of exposure. So what you'll note in both instances, both in Interior Health and Island Health, the workers' right to know in this instance, which is a fundamental right that's enshrined to you in the Workers' Compensation Act, was severely violated. So what are some takeaways and what can we learn from these two incidents? So I think there's a glaring need for employers to audit their existing exposure control plans. So, if there's one thing that you take away from this webinar today, it's to understand what, and Tigran's laid out, I think, quite succinctly, what goes out into an exposure control plan. So making sure that your exposure control plan aligns with regulation and some of the other principles, such as the precautionary principle that we're going to be discussing later. There's a need for employers to audit their reporting and investigation tools to ensure that exposure incidents are adequately reported and that prompt investigations are conducted as per regulation. This is all sort of basic reporting and investigation practices that are enshrined under the Workers' Compensation Act. And then finally, there's a need for employers to ensure that feedback from frontline workers is appropriately integrated into safe work procedures for exposures, and that it is that feedback is gleaned in a timely manner. Next slide, please. So we're going to talk here a little bit about harm reduction and cultural safety. So specifically some of the background of harm reduction in the province of British Columbia, because I do think that the province of BC is in a quite a unique space when it comes to specific policies and procedures regarding harm reduction and cultural safety. So harm reduction is essential in preventing undue health and social harms for people who use substances, as well as BC communities. Harm reduction tends to be evidence-informed. When it's working at its best, it empowers and supports people to be safer and healthier. It reduces barriers to accessing healthcare for people who use substances. It advances the health and human rights of those who use substances, and it aims to prevent stigma and discrimination against those who use as well. Basically, it's an approach that is meant to humanize the ongoing opioid crisis and the people that are in the center of that opioid crisis. Some of the main goals for BC's harm reduction policy were to reduce the number of overdoses by removing the stigma for asking for help and support with addiction, to reduce the toxic drug supply and fatal overdoses related to fentanyl by providing a clean supply of drugs as part of the support and recovery services, and ensure that the efforts of healthcare and union practitioners, community, and policing were all coordinated and integrated, and that there was a teamwork approach to these practices. The main principles for this approach were also integrated into the exemption for the Federal Controlled Drugs and Substances Act that BC received from January 2023 to January 31st, 2026. And under this exemption, adults in BC are not arrested or charged for possessing small amounts, so up to 2.5 grams under the law for certain drugs for personal use. And this includes opioids such as heroin, morphine, fentanyl, crack and powder cocaine, methamphetamine, and MDMA. So a little bit about sort of the unique place in which BC finds itself with respect to the ongoing opioid crisis and the integration between trauma-informed care and cultural safety as well. So with respect to trauma-informed care, a key aspect of that approach is creating environments where users do not experience further traumatization or re-traumatization, allowing them to make decisions on their own treatment needs at a pace that feels safe to them. Integration of trauma-informed care in places such as safe consumption sites. So safe consumption staff are trained in recognizing the effects of trauma and providing a level of care that avoids re-traumatization. These spaces are designed to be non-judgmental and culturally safe. And recognizing that substance use can be a coping mechanism for trauma. So the focus is on reducing immediate risks, such as overdose or infections, to help their longevity. And always with these types of approaches, you'll notice that even with things like trauma-informed care, these are all approaches that are integrated. So the harm reduction approach is integrated with trauma-informed care, which is then also integrated with cultural safety. And cultural safety is sort of the importance of integrating indigenous cultural safety, recognizing the impacts of colonial and intergenerational trauma, including strategies such as involving peer workers who have valuable lived experience in service delivery to build trust, and also ensuring that an LGBTQ2S approach is integrated into policies and procedures where appropriate, and it's also reviewed on a frequent basis. Next slide, please. So with respect to the precautionary principle, this is quite a common principle in occupational health and safety, and it really gained traction and probably gained a lot of attention during the COVID crisis when we were uncertain about the transmission of COVID and whether it was surface or airborne. We had quite a few discussions and extensive discussions on that. But the fact remains that under the Occupational Health and Safety Regulations, Part 6 with biological agents, if a worker has or may have occupational exposure, then employers must develop and implement an exposure control plan that is based on the precautionary principle. And the main basis for the precautionary principle at its core is that when there is uncertainty about potential harm or exposure, it is better to take precautions rather than wait for conclusive evidence that harm will occur. And it's always based on a best practice approach that prioritizes prevention over other approaches as well. Now, it's also important to recognize that we must balance risks and benefits, that it's important to balance the potential benefits of taking action with the potential costs and consequences of inaction. So it does tend to be an overly cautious approach, but I think for the right reasons, but under the right reasons in the right circumstances, it can be an approach that is rooted in prevention and that takes the health and safety of workers and prioritizes that over other approaches that may be in the picture as well.
All right. So we've covered a lot of great stuff here related to the regulation, exposure control plans, and the precautionary principle, as far as that just mentioned. And before we get into some of the specific details of the sampling campaign, we just wanted to touch on due diligence. So due diligence is kind of like another fundamental piece of occupational health and safety, and it sort of ties things together. So due diligence really means that employers are taking all reasonable precautions and actions to prevent injuries or accidents in the workplace, and demonstrating that an organization has taken all that reasonable care to protect the health and safety of its workers. So just a couple of points around due diligence. It's really important that employers, remain aware and are aware, and as it relates to this topic, being aware of our legal obligations under the Health and Safety Act and regulation, including our responsibilities, those pieces that tie to exposure control plan and sampling. And with regards to due diligence, ignorance is not a defense. We have to be aware of those things and uphold our responsibilities. It's also important that employers are objective, in their goal of being duly diligent, identifying issues in the workplace, those hazard assessments, the risk assessments, the exposure control plans, working with qualified people that would be applicable to help us out in these types of scenarios. And being proactive, so developing our health and safety program and making sure that we're taking those steps to reduce the risk through educating and listening to our workers, understanding the hazards, education, and training. And so I think as we move into the next few slides, I'll share a bit more about what this looked like in my organization. So I just want to touch on symptoms of exposure, because if kind of connecting back to what I had shared earlier, this was really what got things started within my organization. We started seeing reports of exposure incidents, and we knew that it was time to take some action. So just on the slide here, I wanted to share the most common exposure symptoms that were reported within my organization. Headache, nausea, vomiting, that's what we were seeing. I think it's also important to note here that fentanyl is a component of the toxic drug supply, but we know that it is certainly not the only thing that's in there. And so fentanyl is something that we can use as a bit of a marker or like a canary, when we're doing our sampling. But when people are exposed to secondary toxic drug smoke, there's a lot of other things in there, right? MDMA, ketamine, methamphetamine, benzodiazepine, other opioids. And in addition to that, we're also dealing with the byproducts of combustion, which contribute to the risks and contribute to the symptoms of exposure. So, if we jumped on Google and Googled what are the exposure symptoms to fentanyl, it would probably say something different than what you're seeing on the slide here. But like I said, I wanted to just share, what our workers were experiencing. It may be similar to some things that you're seeing in your own workplaces. And yeah, understanding that it's not just fentanyl. Fentanyl's our marker. It's what we can sample for. We have an occupational limit for it, but there are a lot of other things mixed in with the toxic drug supply. And then it's interesting to think about the byproducts of combustion or like other fugitive emissions that might be mixed in. One being styrene. Styrene has a long-term, well-established occupational limit. So I guess the short of it is we know that there's a lot going on there that can certainly contribute to the symptoms that we're seeing. And for us, it was many reports of headaches and nausea, vomiting, people needing to go home, people not able to come to work the next day. And that was really what started us on our path to learn more. Next slide, please, Tigran. So following all of those reports of symptomatic exposures, we decided, we needed to follow what was outlined in the regulation and take some action to understand what was going on and be able to mitigate what we were seeing. So this included for us first engaging a qualified person. In this case, it's a regulated requirement to work with a qualified person. In this case, that would be a registered occupational hygienist who has some relevant experience in this area. And following their direction in terms of what they would recommend, the scope of our sampling campaign be. And when we went to conduct that sampling campaign, we followed the instructions from the qualified person. They recommended that we did some ambient samples. So ambient samples would be where we set up a sampling device in a hallway, in an office, and we're just measuring what's in the ambient air around that device. We also did some occupational sampling. So occupational sampling is the term that we use when we actually attach that little pump to a worker as the worker is carrying out their activities in supportive housing or shelter environments. So they're wearing the pump as they're going to do a wellness check or a suite inspection or a building round, and we can really understand what the exposure risks are as they're moving through their day. And we also did some surface sampling. So at our overdose prevention units or our overdose prevention sites, sampling on the tables where substances are handled and prepared. And then how does that look in the office? Is there a risk of surface contamination when we move to the office and things like that? And we always want to base our sampling campaigns on kind of like the highest risk scenario or the worst case scenario. So we wouldn't want to pick a day where we know like everybody from the shelter is going to be maybe out and about or doing something else. We generally in our organization conducted the sampling right after check day when we knew folks were going to be home and, potentially actively using substances that they maybe recently acquired. So considering the timing there. We also completed HVAC assessments. So we engaged with a professional mechanical engineer to come and really talk to us about what was going on in some of these locations in terms of ventilation. From there, we received our results and we were able to come up with some recommendations. So the results really showed us that, yes, we had overexposure happening in many areas. So we identified problematic areas within our supportive housing sites, as well as the overdose prevention site. And then really looked at how we could respond to that through the implementation of control measures. And we'll get into some specific examples of control measures here in a moment. But, engineering controls, how can we change, the design of the air intakes or the air exhaust, administrative measures, rules, procedures, where are people smoking, how are we responding, and then things like personal protective equipment as well. And after we do all that work, we implement all of those controls, we would conduct what's called confirmation sampling. So confirmation sampling is similar to the sampling that you do in the beginning, but the purpose is to confirm the efficacy of the controls that you've implemented. So once you've done all the things, it's like, is it working? Have we done it? And that's a really important step. And in our case, oh, sorry, Tigran, I've got one more thing to say. Sorry if I'm being long-winded. I do get excited about this because it's really nice when you see it all come together. The results, what were the results? So we got a little green check mark on the slide because fortunately we saw some really amazing results. So in our supportive housing site, we saw the air quality was improved by 2,600%. So you can just imagine that's a really big number. Things were not good. We were over the occupational exposure limit by a long shot. But through the implementation of the controls, we are now below it. And in our overdose prevention site, we made improvements between 70 and 90%. So that's just an example of how positive things can be in, doing the work where it's needed to improve those conditions. Okay, take us to the next slide, Tigran. Thank you. So we did just want to share some photos. So for those of you in the chat that were curious about what it looks like, maybe these pictures aren't the very best, but they're what I could pull for us. So you can see up in the top row there, the little blue circles. That's kind of what the pump looks like. So there's a little pump that's attached to a tube, and the tube attaches to this thing called a test cassette, which has media inside of it. And the pump is drawing the air over the test cassette and collecting things in the sample media. And then that test cassette is sent to a laboratory and it's analyzed so we can see exactly what's going on there. So those are a few photos of the ambient sampling. And then with surface sampling, you identify, an area on the surface where you're going to sample at various periods throughout the shift. And then just on the side there is an example of what an air sampling worker log sheet looks like. So the worker would wear a pump basically the same as the one that you see in the little blue circle. And then we track what it is they're doing throughout the day so we can go back and see where and when did those exposures occur. Next slide, please. Okay, so here we're just going to talk a little bit more about those exposure controls. So now that the hazard has been identified, right, we know we've done the sampling, we know we have some exposure risk here. We have to control it. We have to reduce the risk. So let's talk about some of those examples. With the hierarchy of controls, it's often a combination of control types that are going to be necessary to bring the risk down to an acceptable level. And it was really through that comprehensive application of all of the measures that you see on the slide here that my organization was able to see such positive results. So I'll just kind of speak to these from the perspective of my workplace. So, the first thing we want to say is, can we eliminate the hazard completely? Can we physically remove the hazard? So at a housing site, we might say, like, can we 100% get everybody that lives in this building to smoke outside? I don't know about where you work, but for us, that's really hard, right? There's probably going to be some people that are smoking inside, even if all of the rules and all of the signs and all of the consequences are out there. So that's where, if people are going to be smoking inside, what can we do about it through the application of engineering controls? So engineering controls are going to be things like our HVAC systems, our ventilation, our air intakes, our extraction. Other examples of engineering controls, that we applied included making really inviting outdoor smoking areas so that people have somewhere to go that feels good. They can leave their room and go outside to somewhere that's maybe heated, covered from the rain. Other engineering controls that we implemented included like fencing around the building. So if there's a lot of people congregating nearby windows and doors, when the windows and doors open, smoke ingress happens and it's coming into the lobby, it's coming into the office. So are there engineering measures that we can take to mitigate the potential for people congregating out front? Yeah, and with regards to the administrative measures, so administrative measures really relate to procedures and training. And so once we implement those engineering controls, does the risk still exist? The answer is yes, we need to keep layering on our controls. So administrative controls are, things like procedures and training, rules for the site. What do we do if somebody is smoking indoors? How can we apply consequences or try and support changing that behavior? And training for our staff, safe work procedures, the exposure control plan measures, all of those things would be examples of administrative controls. And then the last one that we see here would be personal protective equipment. Personal protective equipment is often referred to as the last line of defense against the hazard. Ideally, we want to be able to reduce the risk to an acceptable level through all of those other strategies. And for us, the sampling campaigns that we did, we learned that there are still some tasks that present a risk that we could not control through engineering or administrative means. In my organization, that includes suite inspections, where there's the potential for somebody to be actively smoking in the unit, wellness checks. And so for certain activities, we've applied personal protective equipment that is sufficient to keep the worker safe while they're entering those higher hazard areas. And we'll talk a little bit more about PPE here in a moment.
Yeah, thanks, Natalia. I think that was well broken down, and I think one of the main or popular engineering controls as it pertains to controlling exposure relates to ventilation. And I want to take you through a few forms of or types of ventilation for exposure control, the efficiency of ventilation, some employer obligations, and then a few different types of examples of sampling procedures. So there are essentially three different types of ventilation. There is what we call general, or maybe more referred to as dilution type ventilation. The most common example that you're probably familiar with are HVAC units, which reduce the overall concentration of contaminants in a space. Then we have local exhaust ventilation, This type of ventilation captures contaminants at the source before they disperse into the breathing zone. Examples that you might be familiar with are HEPA filters and fume hoods. And then we have natural ventilation. So provided that the environment itself does not contain contaminated air, natural ventilation allows for fresh air exchange, and simple examples of this are opening doors or windows or vents. So some factors that affect the efficiency of ventilation are things like airflow control. One common example is negative pressure ventilation. This is a case where air flows into the room from adjacent areas, but does not escape back into hallways or other spaces. These types of rooms should be properly sealed and airflow should be monitored. Requirements for how to maintain negative pressure ventilation, including guidelines on air change rates, can be found in the OHS regulations Part 5 under chemical and biological agents. Another factor that affects the efficiency of ventilation is filtration and air purification. So these are things like HEPA filters and fans that can be provided to provide continuous airflow. And then probably one of the most important factors is preventive maintenance, which is laid out in the OHS regulations and the duty to provide preventive maintenance. The importance of regular inspections to ensure that systems remain effective, including checking airflow rates, replacing filters, and contracting out when necessary to maintain ventilation systems such as HVAC units according to manufacturer guidelines. One important thing to note here is that the employer obligations to provide a safe workplace in terms of ventilation, there is a large obligation on the employer to conduct risk assessments in the workplace to determine the correct ventilation or filtration system that is needed. Systems may need to be added, modified, depending on the environment. For example, for an outdoor consumption site, additional filtration methods may be necessary in the absence of HVAC systems such as fans or other portable filtration methods. A quick note on sort of sampling procedures. Sampling should be conducted by a competent person, in most cases by an occupational hygienist. Examples of sampling procedures include things like airflow and pressure monitoring. So using a pressure monitor to measure and record pressure readings, visual or smoke testing to confirm airflow direction into the room and out for that matter, airborne contaminant sampling, and ventilation performance testing to measure air changes per hour as required under regulation.
Okay, and I just brought in a couple more photos here to kind of illustrate some of the concepts that Farzad was just sharing. So these photos are from our supportive housing site. We made these adjustments, as I said, in consultation with the hygienist, with a mechanical engineer. And in some cases, it doesn't have to be terribly fancy to work. We're a nonprofit, and so it was important for us to be able to find something that would function and be a little bit cost effective. So the kind of the first row of photos there, this is showing fresh air intake that we brought into the hallways to create a pressurized environment in the hallways and like the common corridors. So when individuals open their doors, if they do happen to be smoking in their unit, the pressurization in the hallways is going to push and keep the contaminated air in the unit. The other photo on the side there shows a heat recovery unit that we installed in our office, basically to do the same thing, create a pressurized space in the office with nice temperature controlled air so that it would be comfortable for staff. And then there is one photo that's a little fan there, and I'm going to mention it even though it is a little bit primitive. We did install these fans above our service windows. So after creating the pressurization in the office as an additional measure, putting that fan above the service window to just blow air back out to help create, like a little bit of a primitive air curtain there. And based on the sampling, it worked really well. I think I have a couple more photos there, Tigran. Here are some from our overdose prevention site. So this is a injection-only space where we did some sampling and did find that conditions, despite the fact that people weren't smoking, just the cooking of the substances to prepare for injection created a bit of a hazardous environment. So in the first photo there, it's a little hard to see, but up on the ceiling, there's a blue piece of equipment. That is an extraction device that has a filter that pulls the air out of the space and takes it out outside. And because it is filtered air, we can extract right beside windows and doors. So that was the best option for us. If we had done some type of extraction without a filter, it would have had to be, you know, very up high on the roof because that air would potentially be hazardous. So that's an example of a specialized extraction system. And then I think we've got one more photo. So this is a photo from a similar organization, not from my organization specifically, but this is an example of what a outdoor designated smoking area can look like with ventilation added. So you can see there are some gaps down at the bottom of those glass panels, and then there is a extraction system attached to the other side. So they're pulling up in and up fresh air, and filtration is happening and the air is getting moved out. I share this photo because this is like kind of my dream. I would love to have these at all of our sites here at Kool-Aid because it provides a really nice, comfortable spot for people to smoke while reducing the risk to workers. And also neighborhood concerns and things like that as well, right? Keeping things nicely contained and safe. Okay, I'm just conscious of the time here. It'd be great to do some questions, so maybe I'll cover this fairly quickly. So just the last piece here around personal protective equipment as an element of the hierarchy of controls. So as I mentioned, we through our assessments and working with our qualified people that were helping us, we do still have some tasks where exposure risks exist and therefore needed to consider personal protective equipment, respiratory protective equipment. When it comes to determining the type of respirator that would be appropriate in your environment, I believe it's really based on protection factors. So each type of respirator that you see on the slide here has a different protection factor. Protection factors are assigned to respirators based on the amount of protection that they will offer. So if you do sampling and you see, you know, I'm really like 5 times the occupational exposure limit, you know, the type of respirator is going to be different than if you do sampling and say, I'm 100 times higher than the occupational exposure limit. So this is something that a qualified person could help you navigate based on the results of your sampling, your anticipated exposure risks. You want to make sure that you select the right type of PPE. There is just a note on the slide here about cartridges and filters. So the recommendation from WorkSafe BC at this time, the minimum standard for a respirator cartridge would be what's called a P100. So it's a particulate filter plus an organic vapor component. So it actually has a charcoal component inside the cartridge that's going to address the vapors associated with these exposure risks. So just to say, like an N95 would not be sufficient. We need to have that dual cartridge that provides protection for both the particulate and the vapor. So within our organization, we are using the half mask respirators, and that's based on the sampling that we've done, the risks that we know that are still present, and the protection factor that we know we need. Fit testing and training is also a really important part of this. We can't just be handing out respirators without doing some fit testing and some training. We've fit tested, I think, over 230 members of our team. There are some options out there that I'm sure the HSA could share if you're interested in terms of different train the trainer programs that are available. So you can have some fit testers established in-house, makes things a little bit more efficient and cost effective that way. And once folks are fit tested and trained, you know, there's an implementation piece to all of this as well. And I know that definitely part of the conversation within my organization was, you know, how are all staff going to want to use this? How are we going to get staff to use this? How does this impact service delivery? What does it look like? What does it feel like? All of those things, extremely important parts of the implementation plan. And it's, you know, going to vary depending on your organization, certainly. I just want to say that, you know, talking to the workers and understanding what their concerns are and making it make sense. Little things like we implemented some great respirator bags. They're like just like a nice, stylish hip bag that you can carry your respirator in. People love those. They're using them all the time. And, you know, just a note on the service delivery implications. You know, many of our workers say that, you know, they feel a lot safer. They can actually spend time in these spaces with people without putting themselves at risk. And while it may, you know, initially feel like a challenge to have that respirator on, it definitely can support service delivery in ways as well. So anyways, I think that's all I have to say there. Thank you.
Okay, thank you, Natalia and Farzad. So yeah, just in the interest of time, maybe we can give it a bit of opportunity for a few different questions. I see we have some questions in the chat. Maybe I'll start with the top one. So, do we know why island and interior health regions have been targeted more harshly than Metro Vancouver? Would Farzad, do you want to comment? I think
Sure.
also we maybe don't want to necessarily speculate, but
No, yeah. I think that's a good question, Charisse. I think the media attention was mainly focused on the Summit and Dufferin sites in Island Health, and then the other big incident happened in Interior. So, um, I think the fact that the media attention got the story to blow up in a way that required WCB to or there was likely more pressure on WCB to effectively put in controls to prevent reoccurrence. So that there was some positive media attention that came out of it. I do think there was some very unique circumstances in the way that Summit and Dufferin were originally housed, and the fact that they were regularly functioning long-term care sites, which then had to adjust for a completely complex situation like housing a special population unit, which brings with it an array of complex needs from security to support services, which need to integrate harm reduction and cultural safety. And it became increasingly clear that the support required to integrate an SPU into those types of sites were not available. So that likely added to the ongoing media attention and the fact that the cases weren't resolved for a very long time and still really aren't resolved today. So that's likely why a part of the reason.
Thank you, Farzad. I have another question regarding to sampling. So here from Natalia, how often do you conduct confirmation sampling?
Yeah, that's a great question. In our cases, we followed the recommendations from the hygienist, and we did it once, and we have continued to see a reduction in exposures at that site. So we haven't done any further sampling, but it may depend on the circumstance. I think that's hard to say, but.
Another question. So what was the approximate cost related to testing and implementation of controls and PPE?
Great question. Don't have those notes immediately available. Maybe I should have been a little bit more prepared. So what I will say is the sampling costs have come down in the last 6 to 10 months. Initially, the only laboratory that was doing analysis was in the United States. UBC is now doing that work. So you're looking at the consultant's time. So that's going to vary depending on the consultant that you choose. And then the sample cassettes are between $200 and $300 to run. So it really depends on the scope of the sampling that needs to be done, the size of your, building. But yeah, consultant time plus the test cassettes, which are about, $200 to $300. And then, the implementation of controls is going to vary as well, depending on what you find. In our experience, we were able to work with the mechanical engineer and get creative about some of the engineering measures. But there definitely is a cost associated. But I think it really pays off to be transparent. At one of our sites, we were seeing an exposure incident occurring once every 2.5 days. And that's an investigation. So that's several hours of people's time every time it happens. We were seeing lost time incidents, right? And that has ceased now. So, sorry, I don't have more specific numbers for you, but just to
And
give you an idea.
Natalia, there's a question regarding like how did you secure funding, or is there any funding? Like, can you talk a little bit about like how you went about that? Like, how did you?
Yeah, I mean, I think it's going to be organization specific. And in our case, we've applied to be reimbursed for these activities by our funder. I'm not sure the status of that, to be honest. Yeah. We decided to, our senior leadership team and our CEO decided that it was very important for us to do this, and we did. There was definitely a cost to that. One other element that I'll mention, I understand that one of the primary funders in the province has recently just conducted kind of a broad scope sampling campaign, which included 15 locations in the supportive housing sector. So I anticipate that the results from that are going to help inform other sites. So it, could be through some of the ongoing work that individual employers may not have that burden, depending on how we can use the information from these 15 sites that the funder has recently sampled.
Thank you, Natalia. I see we have a few more questions, and so maybe we'll attempt to save these and answer them to individuals after the call, since we're already over time. So I just want to thank Natalia and Farzad for being our presenters today and sharing us the experience in their organizations and the broader experience. And I want to thank all the participants today that were on this call. So have a great rest of your day and stay tuned, and hope wish you a happy rest of your week.
Thank you all.
Thanks, everybody. Take care.